Okay, good morning everyone. Thank you for coming so early. And we'll start the second day of the third KGA with the hepatology session.
Good morning, ladies and gentlemen. Thank you for joining us in the second day of the KGA conference. It will be session 4 about liver diseases, and I'll present the moderators. I ask the moderators to come to the stage. It's going to be Professor Fuad Ali from Kuwait, Shuaib Al-Ghalaf from Kuwait, as well as Dr. Hisham Al-Dahab from Oman.
Good morning, everyone. First, I'd like to thank Kuwait Gastroenterology Association for dedicating the session to elite gastroenterology, white-collared gastroenterology, which is also called hepatology. And I'm really honored and privileged to present the first speaker, our one and only one, Dr. Muneera Al Tarrah, who is the head of the gastroenterology division at Amiri Hospital and the director of the Al Ghanem Hospital. Dr. Muneera graduated from Kuwait University and proceeded to do her residency in internal medicine at the Kuwait Institute of Medical Specialization, and then she went on to specialize in hepatology, especially in transplant hepatology at King's College. Dr. Muneera is going to talk about non-invasive markers of chronic liver disease. Tafadhali, Doctor.
Good morning. Assalamu alaikum. Thank you, Prof, for the nice introduction. So today I'm going to talk about non-invasive tests for chronic liver disease. And today I'm going to talk about blood tests and non-invasive scores, the direct non-invasive liver assessment, special blood tests, and I'll talk very briefly about our open access MAFLD clinic at Amiri Hospital. So these are the stages of liver disease for non-hepatologists. And this sliced up liver tells you exactly how simple yet confusing dealing with the liver can be. For us to know how to treat our patient, we need to stratify them well. We need to know at which stage they're at. Are they a healthy liver, or do they have fatty liver that requires simple lifestyle modifications, or some steatohepatitis or steatofibrosis that needs furthermore more complex lifestyle modifications, or these patients that have cirrhosis, advanced cirrhosis, and do they need to go for liver transplantation or just for HCC protocol surveillance? So it's quite important to know where are we when we're in terms of dealing with our liver patients. So these are one of the guidelines that I'm going to use today. And this is like a beautiful summarized algorithm that simplifies all the talk into one slide. So when we have a patient that we're suspicious of NAFLD, or now it's called MAFLD, what happens is that when you have a highly clinical suspicion that this patient might be at risk of having MAFLD, we do the simple FIB-4 score. And for those who are not aware what's a FIB-4 score, I'll talk about it in detail. And then they risk stratify the patients. Either the patients go to high risk and they need to get another a secondary assessment, or the patients are linked back to their GP or their primary health care setting where they just have to modify their lifestyle modifications. So the liver biopsy remains the gold standard for the assessment of accurate liver fibrosis. However, it's invasive, associated with severe complications. There's a mortality rate of approximately 1 in 10,000 cases, and it's expensive. Sometimes we have logistical reasons, like we can't have a bed for admission that we can admit the patient for a liver biopsy. Sometimes EOS-guided biopsies, we don't even have the needle available. So this cannot be a screening tool. A NIT screening tool should be non-invasive, repeatable, and not expensive. It's an alternative for the assessment of liver fibrosis, which is highly desirable and, in fact, available. So can we use liver enzymes as a way to monitor chronic liver disease? No. ALT can be normal. ALT is not indicative nor predictive of disease progression or fibrosis. The liver enzymes alone have a low sensitivity. And in this study, 43% of patients with advanced liver fibrosis had normal AST and ALT values. 4.2% of the subjects with abnormal AST and ALT had liver stiffness measurements of less than 8 kilopascals. So they're considered normal with no fibrosis. So in this study, it just shows that when in the setting where you do have elevated liver enzymes, you do have a chance of high fibrosis. And in fact, a 10-point increase in ALT values has a 10% increased risk of elevated liver stiffness. 190 apparently healthy subjects who underwent a medical checkup, advanced liver fibrosis was observed in 11.5% of the subjects with an ALT of more than or equal to 19. But only 2.5% of those with a normal ALT had a high liver stiffness. So, to begin with, if you have elevated transaminases, it should probably provoke that you need to do more tests to rule out advanced liver fibrosis. So, our sturdy friend, the FIB4, it's AST, ALT, platelets, and age plugged into an algorithm, and it gives us readings. So this is a great tool in a primary care setting or in a busy hepatology clinic or a GI clinic where you need to screen to see who are these patients that need more testing. So if you get a value of less than 1.3, this excludes advanced fibrosis with a negative predictive value of more than 90%. So this is an excellent screening tool to rule out advanced fibrosis. However, when you have a higher reading, it's not that great, with a positive predictive value of 60 to 70%, and these patients need a second modality for a liver assessment. So more or equal than the higher threshold and gray zone scores, a second line confirmation is mandatory before declaring the patient that has advanced fibrosis. So these are the INT'L guidelines. I mentioned the AGA guidelines at the beginning, and these are the INT'L guidelines, and you can see that in general that they're all around the same thing. They start with a simple FIB4, and then they divide the patients into low, intermediate, and high groups. So the recent update is that age plays a really important confounding factor, where patients above the age of 65, the lower threshold is 2 now, and not like the patients below the age of 65. So to simplify, liver enzymes are good reproducibility, high applicability, there's no direct costs and widely available, and the patients are getting blood tests anyways. They're quite well validated and can be performed in the outpatient clinic. However, they are not liver specific. Their performance below than the FibroScan and serum markers. The false positives is very high with FIB4 and NFS in patients aged more than 65. And remember that the cutoff points has been changed to 2.0. So this is another fibrosis score. If the patients get a less than or equal to 1.455, NAFL fibrosis score excludes advanced fibrosis. So what it says that all these nets that we can do in our primary care setting is that they're great at ruling out fibrosis. However, always remember, patients that have intermediate or high fibrosis need a second modality. And there are many more scores that we can use. We'll talk about imaging. Abdominal ultrasounds, they're all incidental. They go for something else, they come back with a report that says it's fatty liver. It's divided, the liver itself is divided into 3 grades, mild, moderate, or severe. Sensitivity can be variable from 60 to 94%, and specificity is 84 to 95%. The advantages of the ultrasound, it's low cost, quick to diagnose, it's non-invasive, and it's widely available. However, the disadvantage is that there's a degree of fibrosis not detected, it's low sensitivity if steatosis is less than 20%, it's limited in obese patients for detection of fatty liver disease. Now we come to our current best friend, which is the FibroScan, was the first and the various elastography technique available today and continues to have the most available data. It quantifies the speed of mechanically induced shear wave in the liver tissue and calculates liver stiffness. The liver stiffness correlates well with the degree of fibrosis and chronic liver disease, and especially in MAFLD. And Moses and al. Published the direct comparison, the accuracy of FibroScan has been shown to be higher than those of simple and specialized blood tests. So in 5,000 biopsy-proven MAFLD patients, a FibroScan of less than 7 to 8 kPa had a very good 85% sensitivity, where patients who had more than 12 kPa provided 90% specificity for diagnosing advanced fibrosis. These results suggest that the VCTE is a viable second-line option after simple tests. So the FibroScan is widely used and a validated technique. It's a point-of-care, well-defined quality criteria. It has good reproducibility. Its disadvantages, it requires a dedicated device. And false positive can happen with patients who have acute hepatitis, inflammation, cholestasis, liver congestion, if they were not fasting properly for the test or they have excessive alcohol intake. The 2D shear wave elastography is very similar to the FibroScan, where it's available in most radiological practices. It increases the availability of liver elastography in the context of screening because it's just a simple program and probe that's being installed in the regular ultrasound machine. These techniques are accurate as FibroScans for the diagnosis of advanced fibrosis. So the 2D shear wave can be combined with a regular ultrasound. Its performance is equivalent of a FibroScan. The false positives is very similar to the FibroScan in acute hepatitis, cholestasis, liver congestion, food intake, and excess alcohol intake. The CT scan is not that great to detect fatty liver disease. Moderate to severe hepatic steatosis can be identified when there's specific attenuation picked up by the radiographer. The qualitative evaluation of the liver on the portal vena phase contrast in HAS-CT is highly specific to detect hepatic steatosis, but its sensitivity is quite low at around 60%. Limited accuracy to detect a mild degree of hepatic steatosis. There is a risk of radiation exposure. It's high cost and availability. Not a great tool test for as a screening tool. So MRI elastography. And you can see here in this image where there is, in the top tier, there's the histopathology, the MRI, then the FibroScan readings, and the 2D shear wave. And here it says that morbidly obese, for patients who have morbid obesity, it reduces inter-observer reproducibility and higher success rate. And MRE sits on the top of the tier compared to FibroScan and 2D shear wave. For accuracy, inter-observer reproducibility, MRI is superior to FibroScan and the 2D shear wave. However, accessibility is an issue, cost-benefit is an issue. And when it comes for those complicated patients where they're obese or they're females with narrow intercostal space, MRE sits on the top, secondary to 2D shear wave, and then at the bottom is the FibroScan. So the MRE is most accurate technique for staging liver fibrosis. It decreases intra-observer variability. However, it's not applicable in lots of cases other than iron overload. It requires an MRI facility. It's time-consuming, it's quite costly, and not everyone has access to an MRI. And some MRI places, the MRI waiting list is quite long. I wanted to talk about combining MRI with other scores. So the MAST score is an MRI-based score to identify patients with NASH and significant fibrosis. And what it does is that it's an MRI plus an AST put in a specific algorithm, and we get a specific reading. And the MAST score is an accurate MRI serum-based score that outperforms the NAFLD fibrosis score, the FIB-4 score, the FAST score, and a non-invasive identifying patients at higher risk of fibro-NASH. And actually, these results have shown that not only they identify NASH patients at highest risk for disease progression, it predicts up to 22-fold increase of adverse outcomes from major adverse liver outcomes and hepatocellular carcinoma, liver transplantation, and liver death disease. And it has a statistic of prediction of 0.92, which is excellent. So these patients that are difficult for us to let's say, place them, and we want to know where they are, maybe perhaps doing this combined MRI AST score to help us identify those patients. There's other combined score. It's called the MRE FIB score, where they combined an MRI and a FIB-4 score. And the liver stiffness assessed by MRI, and then when they combined it with the FIB-4, it had an excellent negative predictive value for hepatic decompensation. And you can see at the graph at the bottom, the red line, those patients who had a negative predictive value, they did not have any major outcomes when it comes from the liver disease. But however, is it very practical? Do I need to go that far? Shouldn't the FIB-4 be enough for me to detect those patients that are low risk of developing fibrosis? So the practicality is questionable. Now, quickly to just before the last part, which is the special blood tests. So these are specialized blood tests. Now, we're talking about a primary care setting where the GPs they have access to simple liver function tests and CBC, where we can take the ALT, AST, platelets, and we've got the gender and age. These are like more specialized blood tests, where we need to send them to a center anyway to get these specialized blood tests. So we've got the ELF score, the fibrometer, and the fibro test. And I'm just going to talk about the ELF because a lot of people are inquiring about if ELF scores are available in Kuwait. And the ELF score is that when you have a patient that you've done their FIB-4 and their NFS score, and it comes out not as negative, but however, it's intermediate or high, and you would want to take a step further and examining them more to see if they have advanced fibrosis or not, ELF can be handy, where you can send them to do these certain blood tests to see if they do have advanced fibrosis, just a step before referring them to a hepatologist. However, in my setting, or in Kuwait setting, the ELF test is quite expensive compared to the fibroscans that we already have. So for us, the fibroscan is much feasible and much accessible. So in a patient who had an ELF score of more or equal to 9.8, they're highly sensitive for poor outcomes in terms of cirrhosis, in terms of hepatic decompensations, and liver-related mortality. So these specialized blood tests are diagnostic studies using liver biopsies for the diagnosis of advanced liver fibrosis and chronic liver disease as a reference. Their sensitivity is 80 to 90%. Their specificity is quite high as well. So they can be performed with comparable diagnostic accuracy for the non-invasive staging of liver fibrosis. However, they are expensive. They are best reserved for second-line evaluations of liver fibrosis. Or let's say for a patient that we did the FIB-4, the fibroscan readings were off because let's say the patient was obese, this patient had a contraindication not to go for an MRI, and we need to assess him. Maybe in those cases we can reserve the ELF test for them. They're non-liver specific, and again, they have lots of false positives in patients with extrahepatic inflammatory conditions, profibrotic, extrahepatic diseases, and hemolysis like Gilbert's. Their advantages is that it's good reproducibility and high applicability. They're very well validated and can be performed in the outpatient clinic. There's emerging genetic biomarkers coming, and these are like a few. However, they're all coming soon, and we're not going to talk about them at the moment. So I'm going to talk about the open access Malfold Clinic in Amiri Hospital. Before, we used to get a lot of referrals from the GP clinics where it says that patient would want a fibroscan. And what we did is that we did an online form where the GP puts in all the relative data and an automatic fibroscan score comes up. So the general population approaches the GP and they screen them. If they're diabetic, obese, they have elevated liver enzymes, metabolic syndrome, or even if they consume alcohol, they would calculate their FIB-4 test according to the blood test that's done at the GP level. And then those patients with a high FIB-4 score are referred to us to the open access MAFLD clinic where they get an automatic fiber scan. And then we go back to the original algorithm of INT'L or AASLD where the patients with low scores, they go back to the polyclinic where they get modified for their risk stratification, and those patients who are at intermediate or high risk, they are kept in our liver clinics for further evaluation. This has tremendously decreased our unnecessary referrals and necessary fiber scan requests as well. So, a question to the audience: what's your favorite non-invasive score? Is it with a show of hands, please. So, is it the FIB-4? Okay. Is it a fiber scan? على طول? زين. Is it the ELF score? Or does anyone have another non-invasive test that they prefer? So that's great. NITs can be used for risk stratification for the diagnostic evaluation of patients with NAFLD. A fibrosis 4 index of less than 1.3 is associated with a strong non-predictive value for advanced fibrosis, and we should be relaxed and just modify their risk factors. A combination of 2 or more NITs combining serum biomarkers or imaging for staging and risk stratification for patients who have a FIB-4 score of more than or equal to 1.3. A liver biopsy should be considered in patients where NIT results are indeterminate or discordant. Thank you very much for listening.